Hello, everyone. It's my real pleasure to welcome you all to this webinar from clinical trials to real life. And the question is how to identify non-metastatic CRPC patients who will benefit from the second generation androgen receptors inhibitor. I'm Nicolas Mottet from France, and these are my disclosures with the pharma industry. So what the question? We created a new disease by the early use of ADT, the non-metastatic CRPC. And until few years, this had no practical impact outside patients' anxiety because we had nothing to offer to those men. Recently, a few years ago, we had 3 randomized controlled trials, completely independent, that you will see almost share the same inclusion and exclusion criteria. And all these 3 randomized trials were leading to level 1 evidence of benefits for the early use of drugs of the new anti-androgen receptor inhibitors for med-free survival benefits, and probably even better for an overall survival benefit. So you might ask yourself, is everything so clear so far? Well, probably not so clear. And starting with a very simple question, who will really benefit? If there's a real benefit for all the non-metastatic CRPC patients, or is a subgroup who represent the optimal candidates? Which is the individual price to pay, not in terms of money, but in terms of quality of life? Does this early use of drug is this early use of drug leading to a better quality of life or to a worse quality of life? And finally, as you heard, there are 3 trials, so 3 drugs. Are there a real difference between these 3 compounds? To clarify this, it's my pleasure to welcome Sergio Bracada, who is a medical oncologist from Italy, and Christian Schwentner, who is a urologist from Germany. They will both try to explain in this program how we select the best patients, if the quality of life is maintained, if there are real difference between the various ARIs, and about some discussion regarding the imaging. You know, the imaging is a very hot topic, even if it's not the real purpose of this webinar. So Sergio, the floor is yours, how to identify the best candidate for therapy.
Thanks, Nicolas. It's my pleasure to participate to this important discussion with colleagues from all over the Europe. This is my detail. I am a specialist in both medical oncology and neurology, but working as the head of the Department of Oncology in Terni, middle of Italy. These are my disclosure. And this is the task, because as suggested by Nicolas, what is important for a patient with a non-metastatic castration-resistant prostate cancer? Of course, the primary task is to extend survival and, of course, delay the development of metastases or the knowledge of metastases, because when we are speaking of non-metastatic disease, of course, we are hypothesizing the presence of a micrometastatic disease, but this is not in the way of thinking of our patients. And the task is to maintain a quality of life. I completely agree what suggested by Nicolas Mottet. Of course, this patient has a long expectancy of life, and if quantity is important, quality is of the same importance from the patient, from the physician that manages the patient. To manage this for a longer time is a whole daily task. And in this view, you have to consider also the anxiety of patients that in presence of a continuously increase of PSA, consider the increase of the burden of the disease. And when you perform a diagnosis without success, the anxiety of the patient increases. This is the point of view that you have to share with the patient when you have to consider this new state of the disease. Because non-metastatic castration-resistant prostate cancer is a really heterogeneous as a disease from the biological point of view, and as you will follow from the other presentation, from the imaging point of view, largely present in the United States, probably a little bit less in Europe. And the actual definition of a non-metastatic disease may be a presence of rising values of PSA, despite castrate level of testosterone, and with patient going under an ADT or orchiectomy, but no detectable metastasis by conventional imaging, by bone scan and CT scan, and presence of a prior treatment for primary cancer, radiotherapy or radical prostatectomy in about 3/4 of the cases. But what about the disease? Castration-resistant non-metastatic disease may be a deadly disease. The median time to develop a metastasis is about 2 years, 29.5 months in the curve. Of course, by the point of view of the classical imaging, but we come back on this issue between some minutes, and how we can follow the evolution of the disease to understand the natural history of patients with non-metastatic disease. PSA doubling time may be a good idea because patients with a rapid, a quick or short, if you like, PSA doubling time might have a short time to develop metastasis, as shown in the curve, in the line. Of course, all this should be considered in the pre-PSMA scenario. But using PSA doubling time as a risk factor for the risk of developing metastasis in a short time or long time may be a border to individuate patient, to identify patient with a higher risk of bone mets and death, and to put patient in an observation phase, of course, under ADT, if the PSA doubling time is more than 10 months, or to consider possible options that may be adding a drug, or going to a modern imaging for eventual focal treatment for a PSA doubling time that is less than 10 months. Other factor that you have to consider in the decision making about the single patient that you have to manage in your personal experience may be an high glycerol grade, an high baseline PSA value, and the short duration with initial ADT. What to consider in particular setting? As an example, we may have a patient treated with radiotherapy and long-term ADT for a locally advanced disease, and with an increase of PSA at the end of the treatment with an hormonal agent, with LH mainly, of course. In the absence of relapse, you may consider this as a patient with non-metastatic disease. And when to check the PSA to verify if the PSA is really increasing or not, of course, we have the EAU guidelines that suggest to repeat at least 1 week apart this rise in PSA to confirm the increase, and also to evaluate the increase in terms of quantity, because the result should be increasing the 50% of percentage and an absolute value of at least 2 nanograms per milliliter, of course. No discussion about an eventual radiological progression, because in this case we have to manage patients according to the RISIS criteria, and of course this might be absolutely more than the increase of PSA. In this case we have not a non-metastatic disease, but we have a clinical relapse that we have to manage in a different way. Also eventually adding other drugs, but this is a different setting. How much is relevant the PSA doubling time when to start the calculation? Of course, we have to consider this setting in presence of a negative evaluation, negative workup with bone scan and CT scan, and to manage this patient in the follow-up or in the look for treatment phase according to the entity of PSA doubling time. If you have an initial negative evaluation with classical workup, you have to look for an initial cutoff value of 2 nanograms per milliliter to start for the second phase. and in the presence of a negativity again to reach a new values of 5 nanograms per millimeter. Of course, these are the past of the evaluation of the patients, even if these are the standard again, but with the advent of the PSMA PET CT scan, of course, this scenario is rapidly going back in the past because we are going at new consideration about to consider also this new setting of disease. How often to calculate this? Of course, you have to manage formulas for calculation of PSA doubling time, and we have to follow the algorithm to have at least 3 determination in 1 year to have a correct evaluation of PSA doubling time. And because this is the indication to eventually evaluate patient for treatment with the new drugs that we have to speak about. Thanks, and I'll move to Christian for the following presentation.
Well, thanks for this wonderful introduction and for the initial overview on the different studies that are ongoing in the space of non-metastatic CRPC. And the task that I'll be talking about is whether we can maintain the quality of life in patients with non-metastatic CRPC. And I think there is increasing evidence that we can do so. These are my disclosures in the field of pharmaceutical industries. As we have heard in the beginning by Sergio's talk, or in Sergio's talk, there are 3 studies that have investigated new and novel anti-androgens in the space of non-metastatic CRPC, and they are namely the ARAMIS, PROSPER, and SPARTAN trial. And as you can see, this is quite a significant number of patients that have been included in these studies. And as we heard before, it's all nmCRPC patients with a PSA doubling time of less than 10 months. And it has been clearly shown for all the different treatment options that there is a significant reduction in the risk of death of more than 20% for each single study. Well, as prostate cancer progresses, obviously, as we have heard, quality of life and overall survival typically decrease, and this is just the natural course of the disease. And the transition from non-metastatic CRPC to metastatic CRPC is not only significantly decreasing the quality of life, but it's also significantly decreasing the life expectancy and overall survival. So a delay in of this non-metastatic or clinically non-metastatic period is, of course, very meaningful. When a patient is faced with rising PSA, of course, this is a condition that will cause a lot of trouble and also sorrow in a sense. And these patients are usually, as we heard, asymptomatic in the beginning, and they have no radiologic evidence of metastatic disease measured by conventional imaging methods such as CT scan, MRI scan, or bone scan. What matters most for patients with nmCRPC when additional therapy is needed? I mean, we heard that an extension of life is obviously the ultimate goal, while maintaining the quality of life, which is equally as important, and minimizing side effects of the drugs that are being used is, of course, important as well. Most of us who are facing prostate cancer patients over the course of the disease are frequently talking about PSA, and patients very often scared by rising PSA levels. And it has been shown that PSA by itself, of course, is not it's not harmful. That the PSA rises in the sense that the disease is progressing rapidly, but the PSA increase is frequently causing significant emotional distress. And it has also been shown that pre-treatment there is a significant increase in depression and anxiety, while this is going to decrease in a group of patients that is on treatment and also post-treatment. So there is a significant need for treatment even in a group of asymptomatic patients with rising PSA, such as those with non-metastatic CRPC. Patients who develop metastatic disease, as I said before, are increasingly facing problems to maintain their lifestyle. And this is not only related to the metastatic burden, which causes bone pain, eventually urinary symptoms, and also fatigue, which may also be related to the time on ADT, but also on disease progression, but also due to an increasing mental burden by the disease, as seen here in depression and anxiety, and also a management of the side effects that the drugs are causing during the progression of the disease. So looking at side effects of the different treatment modality options that we have in the nmCRPC space, when we look at darolutamide in the beginning, there is a discontinuation rate during the trial of around 9% in both placebo and darolutamide, indicating that darolutamide seems to be well tolerable in this situation. However, there is also fatigue and fall as a significant side effect. I think long-term data are still lacking, so we cannot fully judge the long-term side effect pattern of darolutamide in this specific situation. But we can have a look at the change in quality of life, and also on also pain, which is of course very important, and that there is a delay in development of pain in the verum arm as opposed to the placebo arm, and there is also a trend towards a better quality of life in the verum arm as compared to the placebo arm, which is a clear indicator for the efficacy of early androgen receptor inhibition, second generation androgen receptor inhibition in nmCRPC patients. Also, in the ARAMIS trial, it has been shown that darolutamide has an impact on bowel symptoms, a positive impact on bowel symptoms, and also on urinary symptoms, which is probably due to the local effect of the anti-androgen on the lower urinary tract and on the prostate, if the prostate is still in place. Likewise, for SPARTAN and PROSPER, or enzalutamide or apalutamide, the results are pretty much the same. So you can see both for SPARTAN and also for PROSPER that the quality of life can be maintained during the study, even if the patient is on a verum medication. So side effects seem to be very tolerable for both other approved drugs as well. But with the time of the disease and the course of the disease, it can be shown that when the disease progresses, quality of life is significantly deteriorating, which happens earlier in the placebo arm, underlining the efficacy of postponing the development of clinically significant metastases in the verum arm. So this, I think, is very important, that the side effects of the medication APA, ENZA, or darolutamide are absolutely tolerable over a longer period of time, and that symptoms will cause a significant change in the quality of life, but not the medication itself. In this space, it's also important to keep in mind that a very high proportion of patients will be on additional medication or concomitant medications, with antihypertensive and analgesics being the most common. However, there is also a significant association of drugs with being statins or antithrombotics, which we all know in this cohort of patients to be very common. So I just want to sort of keep an eye on potential drug-drug interactions, and you should be aware of the different drug-drug interaction profiles of the three approved drugs. So the treatment of nmCRPC should at the end help achieve patient goals, which is of course our utmost goal, which is not only extending life, but also minimizing side effects and potentially guaranteeing an uninterrupted life with a sustained quality of life. So my conclusion for this space, I think nmCRPC is an under-recognized area which still with a very high unmet need. Now having ENZA, APA, and darolutamide available to treat these patients, I think we have come definitely a step forward with acceptable toxicity rates for all three of them and meaningful and similar OS improvements for all agents. And as Sergio said before, patient selection is probably the most important thing to give us very good results in that area. And then I'll hand over to Sergio again.
Okay, thanks, Christian. This is the second part of the presentation. As shared with Christian, we have three similar trials, really similar, because if you look to the methodology of the trial, here are one copy, one of the other. A large size trial in all of the three cases, randomization 2-to-1 for the active drug in respect to placebo. One difference in respect to the inclusion of patients with small pelvic lymph nodes that was possible in the ARAMIS and SPARTAN trial, not possible in the PROSPER, in the ENZA trial. A median time to metastasis that was comparable, another ratio that is similar, some difference in respect to the follow-up. But probably one of the most intriguing considerations that we can hypothesize for understanding the eventual difference in the free drugs is the molecular structure of the molecule, because we are a similar structure for apalutamide and enzalutamide, as shown in the slide, while darolutamide has a distinct structure from APA and ENZA, and this might suggest a possible lower penetration in the blood-brain barrier, and this may be an explanation for what we have shown in terms of increased tolerability, especially speaking about neurological side effects. That might be a reason of interest, especially in very aged patients. As a confirmation of what Christian presented, these are the curves that are really the same for the SPARTAN, PROSPER, and ARAMIS in the primary endpoint of metastasis-free survival or time to metastasis, that is ranging from 36 to about 40 months for all the patients. And we have to consider that this is in terms of understanding more than 3 years of treatment without development of a metastatic disease. This is the surrogate endpoint of overall survival that may be of special interest for young patients with this new setting of disease. Speaking about patients with a family, with young sons, or working in presence of public. And a confirmation about an advantage in overall survival. Again, we have the similar silhouette in the curve of survival and similar hazard ratio, ranging from 0.69 to 0.78, with statistically and clinically significant in both the cases, and with the last update of this curve with a longer follow-up, with ENZA, APA, and DARA. What remains is a shorter follow-up for the darolutamide trial, the ARAMIS 1, in respect to the 2, because the trial started a little bit later in respect to the inclusion of the patient population, and this should be considered when we compare. That is not possible from a methodological point of view, but it's useful for the clinical practice, for data, especially about safety. Because if we have to speak of quantity of quality of life, I completely agree with Christian. We have to consider the absolute value of serious adverse events that are the events that may have an impact in the perception of quality of life from the patient, and with a particular attention to fatigue, hypertension, falls, fractures, and mental impairment disorder. From all of these aspects, we have a constant impact on fatigue. This is also due to the class of drugs where ENZA, APA, and darolutamide participate, of course. Some difference in terms of faults and factors and mental impairment. These three aspects might be of interest, as previously shared, for patients heavily aged, where the autonomy also in the daily living, for considering some aspects or the question of quality of life, things to patient aged and living alone. If you have a fall when you live alone, this might be a problem. Also, the consequence of a fracture due to increased osteoporosis, of course, not to disease. We are speaking of a patient without metastasis, please remember of this. And the impact of side effects may be the major entity of factors impacting on the quality of life regulation that is quite similar to the placebo arms of both of the three trials, of course, and of interest. This is my point of view about mental impairment. In aged patient where the metabolic disease following to ADT is really a problem for patient normally living also in very good condition. An increase of this impairment due to the adding of another drug might make the difference. So in a patient extremely aged, we have to monitor according with the geriatrician that should be part of the multidisciplinary team of the approach to avoid of delay the impact on neurological disorders that may be a real limitation in daily clinical practice for clinician and in daily perception of quality of life from the patient. What about a permanent discontinuation? Discussing about tolerability, we have some in the final analysis difference about the three trials that this may be really due to the difference in the structure of the drug, but this may be also biased also from the different follow-up for the ARAMIS trial respect to the SPARTAN. At this time of follow-up, we cannot conclude in definitive definition about the absolute value of entity of drugs, because we have to consider the entity of exposure to the drug and connect this concept to the entity and the percentage of serious adverse event, even if the feeling may be about a little bit increase in tolerance by Darwin in respect to the others, but how much this is might be significant, I think that might be needed in terms of sufficient follow-up and management of the data in a combination of a clinician involving also geriatrician and endocrinologists. But before all this, we have to come back to the setting that we are speaking about, because remember again that we are speaking of patients without the detectable metastasis with the classical workup, CT scan and bone scan, and we have to consider that we have to treat patients with the APA, DARO, and enzalutamide as strongly suggest, and I fully agree, in patients with nmCRPC and the risk of developing metastasis, to a double task to delay the development of metastasis, to increase overall survival, to increase the percentage of quality of life from the patient. But please treat only patients really M0 or non-metastatic, and considering what we may derive from the new imaging scenario that will be presented in a couple of minutes from Christian. In patient really needing treatment, please verify the PSA doubling time as a good indicator of this patient to avoid not useful treatment for patient might be a favorable natural history without ending drug more. And looking to patient quality of life, also considering comorbidities along the term of exposure to this drug. Please remember again, when you start androgen deprivation therapy, you start a negative impact on the risk of cardiovascular disease. And this patient, as clearly showed before, are present cardiovascular problems, or maybe diabetics, might have drugs that might have a negative interaction in respect to a condition of increased disease deriving from an excess of medicalization of the patient. And in a few words, you have to remember that to start the right drug at the right moment in the right patient. My conclusion are these few. One, please remember that we are speaking about a really heterogeneous and continuously changing disease from both the biological, probably genomic data and imaging point of view. All the three drugs show in the same terms and same entity a significant advantage in terms of metastasis-free survival and overall survival. But remember that the new imaging tool might increase the possibility to identify patients with a real advantage and to move patients with the available identification of a non-metastatic disease at the classical workup as patients possibly treated in the new oligometastatic scenario when not treated for a salvage therapy or radiotherapy in the case of local relapse mainly, and which patient might have a real advantage from adding a new androgen receptor inhibitor, also considering patient age, chronic comorbidities, considering safety, drug-drug interaction, and risk factors, mainly deriving from a PSA doubling time. Starting too late might leave you not able to catch an important advantage for your patient, and this not be the task of any physician involved in the management of prostate cancer patient, while starting early may be useful for overall survival and also to prevent a further dissemination. Please discuss all of the issues in the multidisciplinary team, because this is the real world scenario to have an increased way for management patient with non-metastatic prostate cancer in a way that is useful for the quality of the cure and the quantity of the results that you may provide to your single patient. Hi, Christian, to you again.
Well, thanks for leaving the floor to me once again. So now talking about imaging, and you already set the stage to discuss about imaging, and of course novel imaging has really changed the way we perceive prostate cancer and also the dissemination of prostate cancer, and gives us the opportunity to do a metastasis-directed treatment, which is something that you just mentioned on your last slide. And I would like to start the discussion with a short case introduction, and we'll go back to the case at the end of the presentation, about a patient that appears typical in that scenario, being a 65-year-old patient who is otherwise very healthy, who initially presented with extended disease, locally advanced disease 5 years ago, who underwent surgery with a locally advanced cancer, positive nodes, and adjuvant radiation therapy plus adjuvant ADT for a limited time frame, according to the Briganti protocol. And he did initially well until a few years later he will progress on his disease, and we'll come back to this patient later. But I think it's very important to understand also the individual patient history and who these patients that we consider mCRPC actually are. We heard something about novel imaging, next generation imaging of prostate cancer being PSMA PET, which is in our situation the most frequently used imaging method for patients with presumed metastatic disease. But up to this point, PSMA PET scanning is mainly used for biochemical relapse and to understand a potential local recurrence, or to identify those patients with isolated oligometastatic disease who may be amenable to a intensified localized or distant salvage treatment, and to separate those from the group of patients with multiple distant metastases who may benefit from systemic treatment. And we all know that bone scan and CT scan has significant limitation when it comes to nodal staging and also when it comes to local staging. And there has been a consensus statement that was published just about a year ago with Nicolas Moutet also on the panel, which clearly stated that PSMA PET scanning is currently the most sensitive imaging modality to stage the disease and also to depict metastases at any stage of the disease. However, the use of PSMA PET will definitely cause stage migration, and it will cause stage migration also in nmCRPC to sort of switch it to metastatic CRPC, which is going to change your armamentarium in systemic drugs. And PSMA PET scan should be used as a main imaging tool also at biochemical recurrence after treatment with curative intent, and it should not be used in low-risk disease. So there is, even though PSMA PET is a very good method, there are still some limitations that are inherent to this method. As I said before, next generation imaging is always indicated whenever you feel like, whenever you feel that it enables the reintroduction of a new local therapy that may postpone systemic therapy, as we have heard before from Sergio, that there is a significant risk for cardiovascular side effects if the patient is on prolonged anti-androgen or on prolonged ADT. And the strongest recommendation up to this point is for biochemical relapse after localized treatment for prostate cancer. And that's still the value in CRPC still remains to be determined, and it's still not clear. And this is also being acknowledged by all the different guidelines. So from the US NCCN guideline to the EAU guideline, which was already shown before, over to the ASCO guideline, and all of them come to the conclusion that there is no clearly determined clinical benefit of next generation imaging in castration resistant, and particularly not in patients with an absence of macrometastatic disease in conventional imaging. And at the same time, all of these three guidelines give a clear recommendations for androgen receptor inhibition for patients with a PSA doubling time of less than 10 months who are non-metastatic by conventional imaging. There is very little data in the space of next generation imaging in the field of non-metastatic CRPC. And there's basically just this one quite large study by Wolfgang Fendler, who is actually an associate of Boris Hadashik in Essen, who have extensive experience with PSMA PET scanning in general, but also gathered some experience on PSMA PET scanning in patients with clinical non-metastatic CRPC. And what they did was essentially look at their database, and they figured out to find about 200 patients who underwent PSMA PET scanning in an nmCRPC setting similar to ARAMIS, SPARTAN, or the PROSPER trial. And they have found results that are not very surprising to all of us who are familiar with PSMA PET scanning, and also with the capabilities of PSMA PET scanning to really detect small metastases all over the body. And it was clearly shown that metastatic disease was found in 98% of all patients, and only 2% of the patients did not display any positive PSMA PET lesions. 55% of the patients who underwent PSMA PET scanning in the nmCRPC state were shown to have M1 disease. And many of them, in fact, even showed extrapelvic nodes, which was the most common finding, but also bone mets, and 6% with visceral metastases. I think this underlines the aggressiveness or the relative aggressiveness of nmCRPC and a low PSA doubling time, and also the need to treat those patients early before they develop major and clinically relevant metastases. And again, this study clearly shows that the majority of the patients that we consider non-metastatic by conventional imaging, in fact, are metastatic when screened or scanned by next generation imaging. So which patients are most likely to display metastases on PSMA PET scanning while being still non-metastatic on conventional imaging? It's not very surprising that those with a high PSA at the time of scanning, so beyond 5.5 nanogram per mil, are those very likely to display metastases. Those who had initially diagnosed a local regional disease with positive notes, such as our patient that I showed in the beginning. Also patients who underwent radical prostatectomy and subsequent salvage radiotherapy, and those with primary radiotherapy are those with the highest likelihood of having distant metastases on the PSMA PET scan. When we look at patient characteristics, this, for example, in the ARAMIS trial, and it's the same in the SPARTAN and also in the PROSPER trial, are of course enrolled in these studies and in these trials, and can be investigated and looked at in the post hoc analysis. And it's nicely shown that all the patients that I've just shown before who are at increased risk to have PSMA PET positive metastases still benefit significantly from early androgen receptor inhibition. So the relevance of detecting these metastases early is probably less when you look at the efficacy of the drugs in this particular space. Then again, going back to the patient to show you sort of a role model patient, a role model mCRPC, M0CRPC patient. As I said, initially localized and locally advanced disease. After initial treatment with curative intent and a time of ADT, the patient progressed about 3 years after the initial treatment to a PSA of about 4, and the patient was negative on conventional imaging. And of course, he was seeking for salvage treatment, and we performed the PSMA PET scan, which you can see here, which did not show any significant metastases that could be either handled with stereotactic radiation or surgery. And at the same time, the patient was extremely anxious, so he was put on ADT alone, on the ADT monotherapy, if you will. The patient progressed quite rapidly, again with a PSA doubling time of less than 6 months, and his disease was then converted to M0CRPC. And the imaging was repeated, and obviously this guy was one of the 2% who did not display any metastases on conventional imaging and on next generation imaging. And this is again the course of the disease, and the patient was then reaching a PSA of 4, so going beyond the 2 nanogram that Sergio just mentioned before. And what we did in this case, we use darolutamide in this case. You might as well use enza or apalutamide in this case. And it was nicely shown that the PSA response was very, very nice, going down to less than 0.01 nanogram per mil, which was very nice. And the target, of course, was to prolong metastatic free survival or macrometastatic free survival and maximizing quality of life. And this patient is still on treatment and doing reasonably well. And this is, of course, a role model case for what we want to achieve with our treatment options that we have. So I'd like to conclude for imaging just very briefly. In CRPC, next generation imaging is not recommended, and it's very unlikely, at least up to now, to significantly modify our treatment decision. And all of the 3 most relevant guidelines are not recommending the use of next generation imaging in nmCRPC. And I'll thank you very much for your attention. Look forward to your questions.
Excellent. A very intriguing clinical case to discuss the opportunity of treatment for this patient and maintain the quality of life.
So, are there are obviously some questions So, Sergio, do you want to go through the questions, or does Nicola eventually moderate the questions?
I think yes. I am waiting for Nicolas.
Yes.
There is a comment from Joseph Marinkak. Does COVID-19 infection affect blood PSA levels? Have you data in Germany about this? In Italy, we have not information about this issue.
No, not really. I think there is no interaction with any type of infection and metastatic prostate cancer.
But also about PSA, because PSA is an enzyme. I think that there is no eventual relationship with this issue. The second one is by Hiron Fernando. Presently, OSNA PET, OSNA first possibly is PSMA, is not considered or recommended by WHO guideline on imaging nmCRPC cancer. So when this is the case, when you should consider PSMA PET?
Well, I think PSMA PET, as I said before, PSMA scanning is always relevant when you treat mHSPC to differentiate oligometastatic from polymetastatic disease. And I think it's also very valuable to use PSMA PET scanning as a biomarker for potential peptide radioligand treatment later on in the disease, when you're sort of in the second or third line to treat metastatic CRPC. But as I said, the relevance in the M0 space, I think it's probably very individual. And if you were to detect, let's say, a single lymph node in the pelvic area, and that may be maybe possible, or maybe possible to handle with localized treatment. Okay, that's probably individual decision making based on a multidisciplinary board, but there is no level 3 evidence for localized treatment in metastatic CRPC. So I think that's probably a matter of almost opinion rather than data.
I move the question to Nicolas, because as the chairman of the EU guidelines, because the question involved the rule of guidelines about indication or not. Nicolas, what is your opinion about the second question?
I'm really sorry, I had issues with my connection. Just repeat the question.
Nicola, the question was that the EAU guidelines do not recommend PSMA PET scanning for M0 CRPC. So when is this the case? When should you consider a PSMA scan based on your guideline view? Well,
I will stick with the 2021 guidelines position, which is only recommended at relapse after local therapy if it changes the further management. You won't be surprised that that's a matter of major discussion in the guidelines. And for the 2022 version, that's the one that will be published in March, in the upcoming March at the EAU meeting. I won't tell you now what the decision is, but there is strong discussions about how to position it. I can tell you only that for the non-metastatic CRPC, we all believe that it's totally useless, a waste of time, a waste of money, a waste of everything. And we have level 1 evidence, as you both showed, that the two drugs increase the overall survival for the M0 old-fashioned definition, and that should be enough, except if you consider including a patient in a trial being written in bold with flashing lights, etc., where in this situation you might discuss for targeted therapy. I insist, in trial. Outside trial, it would be an absolute nonsense. And again, I'm talking about non-metastatic CRPC, nothing else. The position of the PET PSMA alone is a completely different story. We had an ESU course, web course on that. but so far it's only limited guideline based on the relapse after local therapy. It's quite a long answer, but I wanted to be as precise as possible. There are two other questions. I'm really sorry, but I was disconnected by my provider. I don't know why. There are two very relevant questions there. Three very relevant questions. Let's start with probably the easiest one. What's about management in those men with a doubling time of more than 10 months? Who will take care of that?
I think that a patient should be lived in ADT and managed with simply follow-up, monitoring the increase of PSI for an eventual future increase, but until the doubling time remain over 10, no adding treatment from the drug point of view, especially because the natural history is in any case favorable and probably not changed from adding other option, increasing only the safety profile of the patient.
Christian, do you want to comment a little bit?
I absolutely.
When would you re-image this guy?
Well, it's always a matter of the trajectory of the PSA doubling time. I mean, if this is increasing at some point, then I would probably re-image the patient. If he is very steadily and slowly increasing, we have seen on this nice slide by Sergio that there is a significant extension to the time of development of clinically relevant metastases. And again, I would probably be very cautious to re-image the patient too often.
I have a similar patient this morning. It's a colleague, and treated with radical treatment 9 years ago. At the moment, he has a slow increase of PSA. 6 months ago was 0.4. Now it's 0.56. And my indication was we will check a new PSA in between 4 months without other indication for staging. If the PSA further increase, we might discuss a new workup.
Well, I will give you the guideline position and then I'll switch to another question. The guideline position is at least the PSA must be above 2. So 0.5, 0.6, 0.7, don't do anything. At least in most of the 3 trials, that was a minimal threshold. And second, we suggest to re-image every time the PSA is doubled. So at least it might be every year, every 2 years, or whatever. Or if there are symptoms that you might suggest might be related to the disease progression. That's a $1 million question. It is asked twice by 2 different people. Do you see in practice a clinically relevant difference between the 3 REs? The other way to ask the question is, how does one choose between Daro, APA, and ENZA? You both made comparison of the 3 trials. So elaborate a little bit. Each of us have 2 minutes to do that, but that's a $1 million question. Who starts?
Well, I'll start first because then I have most arguments.
Okay, please start. I insist.
Well,
clinically relevant.
I mean, as you said, it's always a very individual decision process based on the patient's age, probably, and not on the chronological age, but on the biological age. Decision making will also be based on concomitant medication and potential drug-drug interactions, because all 3 have a different drug-drug interaction profile, with enzalutamide being the most unfavorable for certain drugs, and darolutamide being the most favorable for a certain panel of drugs. Secondly, I would look at the mental state, I would say. If the patient has concomitant neurological disease like a Parkinson's disease or dementia eventually, or pre-dementia syndrome, I would be careful to use enzalutamide and rather use darolutamide in that situation. If a patient has skin conditions, I wouldn't use apalutamide and rather use enza or darolutamide. I think that's probably my take to look at also the side effect potential and the drug-drug interaction potential in every single patient. And I think in terms of efficacy, there is no difference between drugs, which has clearly been shown in many different meta-analyses.
I completely agree with Christian. I simply add two words. The first of all is crossing the data between comorbidities, drug-drug interaction, and the age of the patient. As previously discussed, in very aged people, the problems may be of interest people to select the drug with less risk for this. But we have similar results. I think that for the overall population, we are not able to tailor the selection with one drug in respect to the other. I think that we have to move to 1 year of more of follow-up to our more comparable data between the three drugs. At the moment, especially about the drug-drug interaction, and I have discussed this issue with one of the most important pharmacologists in Italy. We have the perception that with Daro, you have a lower level of interaction with the cardiovascular drugs, statins, and also with the oral anticoagulant that are frequently utilized in this patient, that with the oral anticoagulant, the level of interaction may make the difference.
Well, it's really a matter, I fully agree with both of you. It's really an individual decision, and I fully agree that drug-drug interaction is probably one of the key drivers for treatment selection. The very last question. When progression after one of these drugs, when progression occurs, a possible option is chemo. I just read the message. Would you wait for an increase in metastatic burden to change the treatment, or would you keep going or discontinue the new anti-androgens immediately?
My position is that at this moment, probably I will utilize a new imaging tool. And if we have an oligo progression, I will consider a focal treatment. If you have a bulky progression or progression in visceral progression, I surely move to chemotherapy because of the reduced risk of cross resistance in respect to an ARI. Christian?
Well, exactly the same. If the patient is progressing with symptoms or visceral disease, I'd also switch to chemotherapy and also give additional value to next generation imaging, because it's going to display the visceral metastases more accurately. And I would also, if the patient has a visceral disease, I would also go for a biopsy actually to also make sure that this is really the same disease and it hasn't changed from a molecular standpoint.
Okay, for the sake of time, let's say I partly disagree with two of us regarding the new imaging modality. It's supported by absolutely nothing. There is not a single clinical data showing its value at that stage. I insist, at that stage, while we have strong evidence that when you progress under one of the drugs that might be used there, standard of care is chemo. Having said that, but that's a completely other discussion. Having said that, we need to conclude, and my conclusion will be very simple. We try to clarify who will benefit, and clearly it's a patient who is castrated. So first, check the testosterone. It has to be below 50 nanograms per deciliter, with a PSA that is elevated, and we consider, at least as a guideline, that it should be at least 2 nanograms per ml. And even more important, it's rising rapidly. That is a doubling time of less than 10 months. There's absolutely no place for these drugs in those men with a doubling time of more than 10 months. Second, we are only discussing patients who are M0 based on conventional imaging. I insist, the 3 trials requested a negative bone scan and a negative CT. PET was not even mentioned. Regarding the drugs and what to expect with them, the 3 are leading to a very clear metastasis-free survival, very clear, and a very clear overall survival also, with roughly 30% overall survival benefits, which is very clinically meaningful. The quality of life is absolutely maintained during the drug. It doesn't mean you don't need to follow the patient. You need to follow. All the drugs have some side effect that needs to be followed, but as a whole, the quality of life is maintained. There is no upfront comparison between the 3 drugs, but the side effect profile, and especially the drug-drug interaction, are completely different. So I cannot resist to show you what the guideline is saying. It's a strong recommendation to offer either APA, DARO, or ENZA by alphabetic order to patients with nmCRPC and have a high risk of developing metastasis at a doubling time of less than 10 months, as it prolongs time to metastasis and overall survival. With this, I would love to thank you all for your attention. I want to thank Christian and Sergio for their very nice talk. Remind everyone that you have CME accreditation for this webinar. You will receive tomorrow the link to get it. And finally, I forgot to say it initially, but I have to say it now for transparency. This was supported by Bayer. Thank you very much and have a nice evening. Bye-bye.
Thank you, Nicolas.
Thank you. Bye-bye. Thank you.
Bye, Christian.